of time, you're limiting your remarks to 15 or 20 minutes so we may get a good broad spectrum of the services being performed here would be appreciated. When you speak, please give your name clearly, your area of practice, and the approximate years you have been here at Grandview Hospital. As you know, this is being taped, videotaped, and audio taped, and we will now start the discussion, and then we'll have a break for the luncheon. Perhaps maybe could we start with Dr. Berger giving us some background as to the early administrative and development of the profession in the earlier years. Which station?
I don't know if I'm going to be able to do much of a job on that. The first person I really ran into might
Please
have
state
been
your name and hello.
Oh, Bob Berger. And you, what else do you need? That's it? The first person in administrative work was a part-time man by the name of Arnold Trickey, who was broker, stockbroker, and did this work here at Dayton Osteopathic Hospital on the side. And interestingly enough, it's been less than a year since he died. He, up into his 90s, I believe his son told me. But then the staff wasn't quite satisfied with the way that arrangement was, and hired Bill Cano. Most of you have heard of Bill Cano. Had him come down from Columbus and run the office. Bill Belide was house physician, and Jack Miller, what happened to Jack?
He couldn't make it.
He was one of the interns in those days. Charlie Moon, I guess, was what you might say the first intern that we had here. Charlie was still alive the last I heard.
He just finished his internship. He just finished his internship.
Jack Miller, and then there was a fellow by the name of Lacan, Bert Lacan. And he was the same year graduation that I was. Lacan, we served half our internship together. I originally started my internship in Omaha, Nebraska. And, well, after being there about 3 months, the Attorney General ruled that DOs couldn't do surgery of any kind. And they could do obstetrics, yeah. They could do a C-section if needed, yeah. But they couldn't circumcise the baby after. How foolish their regulations were. But be that as it may, I got on the phone and talked to Dr. Frank Dilatush, and he said, he had a place for me here, so I came back here. And then with Dr. Rainier, I think, what year did you come?
I interned in 43 with Dr. Shade.
You were with me.
Eugene Young.
42, 43. You were with me, weren't you?
No, you had finished.
No, I hadn't. No.
Oh, that's right.
Excuse me. You came in, I came in July, July or August. You came in January.
I came in December of 42.
December 42, yeah, okay. See, I came in July of 42. Okay.
In the office end of the building, Mr. Fricke's, although he did a pretty good job, he just didn't have enough time for the hospital and his regular work too. So the staff arranged with Bill Connell to come down and take over. Bill right away delegated his authority to a lady by the name of Treadway. And the only problem with Treadway was that she had to call Bill before she did anything. You know, there wasn't much help. The staff again was dissatisfied and decided to, Bill, they couldn't get any better help from Bill Connell. They couldn't get anything from Treadway. So they decided to look elsewhere, and they ran across a man by the name of Joe Back in Cincinnati, who was an employee of the Board of Health. And Joe was hired as really the first full-time administrator. Meanwhile, the staff was growing, and these various departments were growing too.
The Open program will begin at 12 noon in administrative conference rooms 1 and 2. The Open program will begin at 12 noon in administrative
staff
conference rooms 1 and 2.
accreditation and so forth amongst the members left a little something to be desired. Somebody said, "Well, I'm going to be the internist," and somebody else said, "Well, I'm going to be the proctologist," and somebody else said, "I'm going to do this and that." And that's sort of the way the departments grew. But they prospered, and the staff can owe a lot to where we are today to cooperation and hard work amongst themselves. I think you all, anybody here doesn't realize that. So, Dr. Krause, you can take it from there.
I tell you what, I have something I have written because Jim Laws had asked something about Department of Surgery earlier, and this is just a little sketch, but then I sent a letter to Dr. Jim Elliott, and he wrote me something back. So if it'd be all right with you, because I think as I read these, it'll bring back some memories and some help you recollect some of the things that have taken place. I remember one of Roger's anesthesias years ago. I know you didn't know that Roger was an anesthesiologist. Well, Roger was an anesthesiologist. Well, let me just read this. I'm William Quinlevin, and this was what I wrote and gave to Jim Laws. And then I'd like to quickly read what Jim Elliott wrote, because he brought to mind a lot of things that I had not thought of. In January 1949, I flew to Dayton, Ohio from Syracuse, New York, where I had been in general medical practice for 3 years. I was interviewed concerning my application for a surgical residency at Grandview Hospital. While in Dayton, I met many staff members, for I attended a hospital staff meeting when I came down at that time. I met and was interviewed by Dr. Frank Dilatush, Dr. Melvin Schubert, and Dr. Richard Dobolite. I also remember meeting Drs. Zimmerman, Carter, Bradford, Stingley, and Kahn. Grandview at that time had no intern staff, and the hospital was covered by staff physicians on a rotating and voluntary basis. I was applying for, and this is at the Grand Avenue Hospital. The 2nd Street was before my time, but it was only a couple of years or so before my time. I was applying for and was accepted to be the first general surgical resident. Dr. Paul Kraushaw and Dr. Harry Adams were surgical preceptors, but I was the first full-term AOA-approved resident in general surgery. After acceptance, I returned to Dayton to later begin my residency program around the middle of April in 1949. My wife Lorraine was finishing her senior year at Syracuse University and would join me in June after graduation. We were to live at 3455 Oaks Avenue, which was a short walk from the hospital. At that time, I think I was the only resident at Grandview, and I believe, and this is where I apparently am in error, I believe that Dr. Charles Wynn and Dr. Donald Burns were soon to become residents in medicine in either 1950 or 51. And I believe I'm early on that, right? About the same time, we started building an intern staff, and Dr. C.W. Elliott became an intern, and later followed me as the second resident in our surgical residency program. At that time, we actually had a Renaissance type of program, and we scrubbed on orthopedic, urologic, as well as general surgery. At that time, general surgeons did all the gynecological and obstetrical surgery. I recall both Dr. Elliott and myself really enjoyed the challenge of the different surgery disciplines. With few interns, the surgical resident had more work and examined every patient before surgery, did the history and physical examination, scrubbed at the operation, and performed the postoperative care. We did much more internal medicine than surgery residents do today. Part of that was because there were few residents in internal medicine. As I recall, the internists were Dr. Milton Zimmerman, who, though most interested in gastroenterology, did general internal medicine. Dr. Nick Carter read EKGs and was concerned with cardiology, as was Dr. Stingley. This is apropos to what, Bob, what you were saying about everyone who just took on their field of interest. Nick Carter read EKGs and was concerned with cardiology, as was Dr. Stingley. No surgeons at that time at Grandview Hospital performed either thoracic, vascular, cardiac, or neurosurgery. And when these were diagnosed, they were sent to other hospitals. On finishing my residency program in 1952, I opened an office on Salem Avenue for a few months, but then was offered an association with Dr. Frank Dilatush, which I was pleased to accept. During my residency and in days of my subsequent private practice, I had many interesting and exciting surgical cases. I was to go for 30 years without a malpractice case. Suing your doctor was a very unusual circumstance, nor do I remember that anyone else had any real malpractice problems at that time. In a previous paragraph, I mentioned that general surgeons did the obstetrical and gynecological surgery. In fact, most of the general surgical practice was gynecologic. Surgeons limiting or specializing in obstetrics and gynecology had not really come onto the scene at that time. It was my pleasure to deliver 3 sons by cesarean section to Dr. Frank and Bertha George, and they now have grown, their sons have grown to have their own families. Because of the special relationship between family doctor and the specialist, many close and meaningful friendships developed. At that time, we had not yet been embraced by the MDs, so we were wonderfully dependent upon each other. I'm not sure that many specialists of today can enjoy the thrill of medicine and surgery as we knew it then. Doctors determined the course of treatment and enjoyed a fraternity with patients and other doctors in all specialties. Another perspective would be revealed when I say that my pay my first year in residency was $125 a month, plus room, board, and laundry. Each succeeding year, it was increased by $25 a month, and when I finished, I was receiving $175 a month. So from these figures, you can see how much time has changed. I continued to build a general surgical practice until I had the opportunity to take a fellowship in neurosurgery at the University of Montpellier in 1959 and 1960. Professor Claude Gros was a trainer, and he had studied neurosurgery in the United States after World War II. He spoke English, and we became very good personal friends. This friendship has continued throughout the years to include several visits to France on my part, and his visit to the United States and to Grandview Hospital in the early 1970s. My period of study in Montpellier was at times difficult, but as I acquired more facility with the language, the experience became greater and more appreciated. I had the status of foreign assistant, and participated actively on the neurosurgery service. During that time, I wrote a paper on spontaneous intracerebral hematoma, which was a collection of 125 cases on that service. And I was delegated to present this paper to the Middle East Neurosurgical Society in 1960 at their meeting in Beirut, Lebanon. Even then, Beirut was in political turmoil. I read my paper at the American University in Beirut and was among the members of the Congress to be received by the mayor of the city. He was a member of the Phalangist Party and was greeted by a crowd outside the university with a fascist salute, which is the raised and outstretched arm. This surprised me because I thought World War II had ended fascist government. As I learned more of European and Middle East history, I realized that fascism persisted in Spain under Franco for several more decades. When I went to Montpellier, I took my wife, 2 daughters, and a Chevrolet station wagon. I thought that the Chevy was a small car, but it proved to be very large besides smaller French automobiles, and always gathered attention when I would park it at the hospital. Some of my French friends at that time nicknamed it the Dragon. In 1959-1960, France was embroiled in political dispute with Algeria, which resulted in warfare between Algerian rebels and the French army. Naturally, many civilians were injured, and these casualties were flown to Montpellier. I saw many head and spinal injuries from gunshot and shrapnel wounds. I often wondered at the time that this experience would be meaningful to me, for I was more interested in cerebral aneurysms and brain tumors, which I thought would be more pertinent in the civilian neurosurgical practice. I was later to realize the benefit of my trauma experience when I encountered many gunshot wounds to the head and spinal cord during the troublesome 1970s and 80s in Dayton. In 1 year in the late 1970s, I took care of 26 cranial and spinal wounds. I'm sure my neurosurgical colleagues today are continuing to see cranial-spinal trauma as a result of our present violent culture. I remember one patient who had multiple wounds of the abdomen, heart, and head. Dr. Tom Hetzel and I operated the patient. He operated on the abdomen and repaired the intestinal wounds, and I operated on the head. Following both of our surgeries, we then both opened the chest and removed a bullet which had penetrated the pericardial cavity but had done minimal damage to the heart. I believe this was probably one of the very first thoracic cases at Grandview Hospital, and incidentally the patient made a good recovery. Dr. Jim Elliott and I were accepted into our surgical staff, but not without very visible reluctance on the part of an older surgeon. Later, we were to accept Neil Caldwell and Sparrows Gabriel on the surgical staff. In spite of the fact that we all felt that the pie could not be cut into smaller pieces, we built our surgical practices successfully. Later, Tom Hetzel was accepted on the staff. Probably our individual success was due to the fact that the general staff was also building, with more and more interns staying in Dayton and opening general practice, now known as family practice. Most of the GPs met with exceptional success, and their section developed and grew. It should be remembered that the GPs in those days delivered babies, performed minor surgery, managed large volumes of hospital patients, and they also assisted in surgery and formed a valuable link between the patient and the surgeon. Early Grandview had financial problems, for we were not receiving full billing from Blue Cross and other third-party payers. Full billing was to come later after much political pressure exerted by influential friends of osteopathic medicine. To be on the medical staff at Grandview Hospital in the 50s and 60s was a privilege and not a right. After professional acceptance, a surgeon was assessed $10,000, which he was allowed to pay over 3 to 5 years. In addition, each major surgery was assessed $10 and each minor surgery cost $5, which was payable at the end of each month. The internal medicine physicians had to pay a $5,000 assessment and then pay $5 for each case they treated in the hospital. As the hospital's good fortunes improved, many of us felt that the assessment was unnecessary and that it was a cushion that underwrote some poor administrative practices. It was eliminated, but not without much hard feeling between staff and administration. When I first arrived at Grandview in 1959, I believe we had 90 beds. The obstetrical section was located where the present admissions office is now situated. With many GPs doing obstetrics, There were years when nearly 2,000 deliveries occurred. Several general practice physicians would deliver over 100 or more themselves. In fact, obstetrics was so successful that the present obstetrical wing was built to accommodate that need, and both floors were busy. Later, another bed addition was added, which is the large building now facing Grand Avenue. In 1960, Dr. Fred Hours, John Snyder, Quinlivan, Macaulay, Edward Levine, and Ralph Dager built the Forest Grand building and conducted their practices there until the building was sold to Grandview Hospital in 1983. The hospital now uses this building for administrative purposes. The Forest Grand building parking lot is now occupied by Ohio University College of Osteopathic Medicine. I have related some of my personal professional development, and I hasten to add that other medical departments and physicians were also growing. The Department of Medicine was developing expertise in gastroenterology and cardiology, and Don Burns was pioneering respiratory medicine. He evangelized the use of intermittent positive pressure therapy, and nearly every patient who went to surgery received this treatment before and after their operation. Later, this practice fell into disfavor, but I always personally felt that it was useful, and Dr. Burns can explain. In the Department of Surgery, Dr. Harry Adams and Dr. Robert Butts were developing a specialty of urology and widening the scope of their practice. Dr. Lyman Leidig trained several residents in ophthalmology who remained at Grandview and built this specialty as well as that of eye, ear, nose, and throat. Dr. Warren Bradford was our first surgical orthopedist and was followed by and associated with Dr. Don Seal, whose great interest in academics led to a very successful orthopedic residency program. I have always admired the orthopedists and their training program. When I returned from France in 1960, I undertook to develop the practice of neurosurgery. This was a daunting task because ancillary diagnostic tools such as CAT scan and MRI was so far in the future. Neurosurgical diagnosis in 1960 was dependent on cerebral arteriography, pneumoencephalography, ventriculography, and rather primitive nuclear brain scanning, which was of limited localizing value. All of these procedures involved X-ray, and the Department of Radiology was also experimenting and growing. Seriography, or the taking of multiple X-rays in a matter of a few seconds, was not as yet within the scope of the Department of Radiology. At that time, the Schoenander seriograph, which was made in Germany, was the state of the art. It cost many thousands of dollars, and it was several years before Grandview purchased one. In the meantime, with the expertise supplied by Dr. Conway and the hospital carpenter, we built a unit which we used to take serial X-rays in the anterior, posterior, and profile positions of the head. Each film had to be fired and pulled by hand to accomplish serial arterial, capillary, and venous phases. This was a rather crude maneuver, but I still marvel at the many good films we made. We became very good at arteriographic diagnosis of aneurysms, subdural hematoma, and tumors. With this homemade seriograph, the Department of Radiology went on to purchase a Schoenander unit and develop radiological diagnosis of the vascular system of the whole body. Today, aggressive radiology includes coronary artery study of specific organs, and many other high technical diagnostic and therapeutic methods. In the osteopathic profession, in the early days, there were only 5 of us who were certified in neurological surgery. These doctors were Dr. Ray Ruberg of Philadelphia, Armin Maruk in Tulsa, Jack Renault in Columbus, John Ziegler in Detroit, John Ziegler who having interned here prior to going to Detroit, and myself in Dayton. From this beginning, we all developed residency programs which have since introduced many neurosurgeons. It was my pleasure to train Dr. Robert Biggs, Dr. Goodall, and Dr. Baker. The training program has continued on my retirement under the guidance of Dr. Tom Goodall. These residents in turn have continued in the development of neurosurgery by acquiring skills in microsurgery and other innovative procedures such as ventriculoatrial and peritoneal shunts. I would like to finally comment that my period of surgery at Grandview Hospital from 1952 to 1985 was indeed a golden era, marking the transition into high-tech medicine and surgery. Our adversities at that time were actually blessings in disguise because they gave us great impetus to study, to learn, and to improve our knowledge and skills, as well as integrate Grandview physicians into a wonderful bonding process. Today we have fewer professional adversities, and our bonding as a medical staff has suffered. The test by fire remains how we deal as an osteopathic profession with the healthcare system, which is about to begin. So that was my
Thank you, Dr. Quinlevin. I think we'll take a little break now and finish our lunch, and then we'll continue after the lunch. Okay?
Go ahead, anytime.
Okay, go ahead, Fred.
Fred Hours. I was in the Department of Orthopedics. I happened to be the first orthopedic resident here. I didn't scrub just in orthopedic surgery. I also scrubbed in general surgery if we didn't have any orthopedics that day. I lived on Bar Hills Avenue in Oakwood, and Dr. Gilatush would drive by there every morning about 7 o'clock, pick me up, take me into the hospital. So if we didn't have any orthopedic surgery, I'd scrub it in. We just were talking a little bit ago about this turning the telephones off to patient rooms at 9 o'clock. I had this policeman in bed, in traction, in one of the front windows in the building on Grand. And he looked out the window, saw somebody breaking into a car, broke the window, got in, took out the radio, left. Went to the next car, broke the window, broke in, took out the radio, left. And the policeman tried to get out to call the police station, have a policeman come. He decided himself he couldn't do anything. He had a pin through his, just a femur. He lost traction. And the fellow broke into 3 cars. This policeman was beside himself because he couldn't do anything.
I had to laugh as I was going through here. One of the questions, this is a developmental program by Dr. Don Seal, and one of the questions raised by the staff is, should we consider a satellite hospital? Mr. Back's view was that we should not consider a satellite hospital until Grandview has reached 500 beds. We wouldn't have one yet. It was reported that there is a newly constructed nursing home in Washington Township. The quoted purchase price is extremely reasonable, giving us a potential of some 100 beds at low cost. The special committee decided to arrange contact with a realtor to obtain an option and a price quotation in writing. This was in 1967. There were some foresighted people then.
What was the story, Fred, when Joe Back asked you asked Joe Back if you went to Target?
Well, one morning, surgery schedule was tight, practically nothing on it. So all the interns and residents were free by 9 o'clock. So most of us went down to the interns' quarters. We had some real good bridge players, Pickens and
Rankin Ray Pickens. Remember? Rankin? He was from south of the river. Yeah, it's somewhere down. Rankin Ray Pickens. Yeah. No, Rankin.
And then his bridge partner, his last name started with a T. think right now what it was. But they won the bridge tournament at the Shrine one year. So this day, we were down in the entrance quarters and we were playing poker. Well, somehow, word got around to Joe back that we were down there playing poker. He came in and he stood there. You could see we were playing poker, so I invited him to sit down and join us. His face turned red and then turned white. He turned around and walked out, and he reported me to Dr. Bradford. Dr. Bradford talked to me and he said, now next time you play poker down there, lock the door. Now, the orthopedic department always supported the idea of having more men in the various departments. And the one that I recall encountered considerable resistance to getting on the staff was Dr. Gabriel. And the orthopedic department supported him as best we could. He did get on staff. You mentioned the parking lot of Forest Grant Professional Building. The hospital bought a corner of that lot before we sold the building to put the oxygen tank out there.
The doctors also gave the hospital the land rights to permit them to dig the tunnel that went from Grandview Hospital to the annex.
That's right. The orthopedic department always had felt that education was the best way to limit the number of people in a department. We didn't feel that a person should be denied privileges in a department just because there was a stated number in that department already. When I started my residency, we had Dr. Bradford and Dr. Seal. Before I retired, we had 8 orthopedic surgeons. And our program was approved for 8 residencies at that time. I think now it's approved for 9, but I'm not certain about that. Dr. Bradford died in Boston at a convention. A group of us went out to dinner the night before he died, before the convention ended. And he had a lot of swelling in his legs. And I understand he died in the lobby of the hotel. Check it out.
Was that congestive failure or? Leg swelling?
With the suddenness of it, I thought probably had a pulmonary embolus. He had hypertension. As a matter of fact, before I came here, Dr. Heliotis came down and covered for him for a period of time while Bradford, I believe, went to Florida for rest. I started here February 1953. I retired December 31st, 1986, when my malpractice insurance went out. It was supposed to go up 50% next year, and I thought it was a good time to call it quits. Dr. Quinlevin said that malpractice was not a common thing back then. Well, it wasn't, for the most part. But I started out in general practice in Corpus Christi, and they had one orthopedic surgeon there at that time. He had 7 lawsuits pending at one time. So I didn't refer any patients to him.
I started interning on New Year's Eve in
Say who you are.
43, Morgan, George. I remember distinctly that night because it was very cold, and it was so cold up in the entrance where we had 2 little electric heaters. I had to sleep with my overcoat on and my shoes, put everything I had on. But I remember how much camaraderie we had in the hospital in those days. I mean, I had very little training, if any, from the school except for didactics. I had no practice. And I started out in the laboratory. I had to work with Boyce, and he helped me a great deal. And then I was fortunate enough to get into surgery. And in those days, the intern was the first assistant. And I remember Percia Guard was a nurse at that time. And you just literally scrubbed all the time with Frank as first assistant. And who was the doctor's name in Columbus who was a surgeon?
Watson.
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 And D.O. Watson would call down and get Frank to come up there to Columbus to do the surgery for him when he was absent. And Frank would take Percia Guard and myself up to Columbus, so we do the surgery up there in Columbus when Watson was gone. But in those days, you didn't get too much training from the men on the staff. You were supposed to look everything up. And I remember Dr. Young from Lebanon had a lot of OBs. And this time he called up and said he sent one in, wanted me to deliver. He said, she's got eclampsia. I said, I don't know nothing about eclampsia. Well, he says, it's time to learn and get your book out. And that's the way it went. But we were allowed to, the interns were allowed to do, and the physicians on the staff were allowed to do a lot in those days. At Columbus weren't allowed. Columbus, they weren't allowed to, I don't think they even could admit patients without going through the medical staff, the internists. And so we were allowed to do a lot of things. I remember Dr. Quinlevin, he probably doesn't remember that, but I went out in the office and went out in the waiting room, and here's a man sitting holding his leg, and with blood all over the floor. Come to find out, he had been up in the attic sawing with an electric saw, and his son came in and said something to him, and he dropped the saw, and he cut himself from the hip down to the knee, just right straight there. And you had just started your residency. I don't remember whether you were there.
I don't remember that.
But we spent all afternoon seeing to me sawing it out, and Dr. Bradford sat on the bench over there watching us the whole time, and then reported it to seal that I wasn't allowed to do that. And I remember Dawn saying, well, he's got minor privileges, and it's okay. And it wasn't a bit. Yeah.
You know, one of the things that you just touched on there that I always enjoyed very, very much, and I am sure the rest of you did too. And that was the sessions we used to have down in the Department of Radiology, in the old radiology office. It would just seem that no matter what the medical problem was, we'd get together with X-ray department down there, and we would cash these things out, and there'd be different ones that have different opinions, but have read different articles, and I always thought that was I always enjoyed the kind of discussion that we had on medical cases when we would go down and review X-rays with you, Jim.
Well, I think that was the beginning of the tumor board, too. We organized a tumor board here.
What year was that, Jim?
When were you talking about?
Well, that was through the middle and late 50s and early 60s.
Yeah. I think the original tumor board consisted of Dr. Bodette and myself from X-ray, Dr. Elliott from surgery, and the pathologist, Al Verano. That was the first organized tumor board here. In fact, we were so new in it that we were asked to go to different locations to tell them how our tumor board went. I think even the College of Surgeons.
Yes.
Our group presented our organization, how we function. And so this was very early in tumor board recognition. I'm sorry.
That's right. Why don't you, you have more to say, Dr. George?
No, except when I look back on for 50 years, there's such great changes. But it seemed to me one of the things that I'm noticing now is really I think we were responsible for what's called holistic medicine now. I think it was our attitude and our mannerisms with patients, the fact that we treated them just as though they were human beings and not just someone to diagnose. And it seems to me that what I see is missing now is that family physicians don't go into scrub with every case as we did. They don't go into they don't manage the care in the hospital. We even took care of coronary cases in those days, and did about as well as anybody did. And it seemed to me that we're missing that now, and that it's going to get worse instead of better. Because now, it used to be I'd know what was going on when they had surgery, when they come back, and I could talk to them about it. And now you get the reports, but you don't go into scrub, you don't know what's going on. And I think, I see that as something that the family physicians are missing.
There should be a little more of that.
Yeah.
I mean, did you ever send a patient to an MD and on the average, you pretty well got a response.
Yeah.
Thank you note and so on. Our people don't do it. A lot of them don't do it.
And if you don't go to the hospital, you see, I had it just happen the other day. That's right hit home to me, and I didn't realize. I got the report and all, but I didn't realize some of the complications she had, and it made me feel bad.
And in line of that, as I recall, the problems. I'm Roger Bennett, an ex-anesthesiologist. The reason that the family physicians were kept out of the surgery was so that the residents could get their training. And there was a pretty hot situation developed with the residents if they'd see a GP in there and they couldn't get in to scrub. Dull silence.
I never found that to be true. The residents would gripe at me, but I didn't pay a whole lot of attention to it. I scrubbed. I don't ever remember not being allowed to scrub, except just in the last few years, for one reason or another, I haven't done it. I even scrubbed on an open heart. I didn't know till after I got done that I wasn't supposed to, but nobody said anything about it.
Well, of course, there's another factor there too. You got a kickback
No,
when you scrub.
no, we never got it. Well, we did years and years ago.
Yeah.
That's what we got.
Yeah.
No, not in the last, 20 years.
Oh, no, not in the last 20 years, but originally that was the idea that the GP get in and the surgeon would get around in the lounge and he'd pass out his divvies to the fellows that referred him cases. Of course, that was done away with many years ago.
Dr. Fox, excuse me.
I can relate a date as to when fee splitting ended. Not the exact date, but I remember when I finished my residency, they were still splitting fees in Michigan, but not at Grandview.
Oh, yeah, Michigan.
That was in '56.
Yeah. I know Biggs up there in Michigan, that was his big thing. He'd sponsor interns, set them up in an office so that they could refer him to surgery. He had an empire built on that basis at Detroit Osteopathic.
Dr. Fox, would you care to give us some background of the Department of Radiology?
I'm James Fox, radiologist. That's about the only thing I can tell you, really. Department of Radiology has always been one of those things that a necessity they didn't want or something, I guess. But we always got back in a corner someplace with the least amount of equipment, or at least that's the way we felt about it. I had to start back with my internship to indicate how the X-ray department really became a functioning part. During that internship, Dr. Doblight, he was house physician, radiologist, the whole bit, stocked the furnace. I had sort of showed some indications that I kind of liked X-ray, so he let me do everything I wanted. I was doing GIs and IVPs and the whole bit during my internship. And so I thought, I kind of like this, so I started looking around for residencies. And I was told that the Detroit Osteopathic Hospital had the best residency in our profession. So I wrote them a letter. I think it was in December, possibly. I interned from July through 42 to July of 43. So this would have been somewhere in December of 42 that I wrote a letter. Didn't hear anything. So finally, when I finished my internship in July of 43, Dr. Doblight wanted to go away and get some work on proctology. And he asked if I would stay on as house physician, which I said I would. And about that time, I got an acceptance for a radiology service at the DOH hospital. Well, that really put me on the spot. And because I was house physician, radiologist, and the whole bit at that time. Well, anyway, I gave him an extra month. I was supposed to have been up there July 1st, and I think it was middle of August before I finally got to Detroit. Anyway, I did leave earlier than I should have. Well, that was about the last that I could remember as far as the old hospital was concerned. I went to Detroit, started my residency in August of 43. Well, my residency went through, I had a 3-year residency, then I stayed on as an associate radiologist, and then I went to Flint, Michigan, and I practiced up there for 2 years. And then I got a call from Joe Stiles. He had become the radiologist at that time. And he said that he was planning on moving to Arizona and wanted to know if I'd be interested in taking over the department. That he had talked to Joe Back and he had recommended me to him. So anyway, the following weekend, I came down to talk to Joe. Now, I had a resident, Spencer Hilton. I don't know whether you remember him or not. Sure. He was with me in Flint. Well, I came down, I think on a Friday, and I talked to Joe Back on that following Saturday morning. In the meantime, at that time, I got a call from Flint and said that your contract has been canceled. I didn't think they even knew I was looking around. But this showed you just how things moved at that time. There was one fellow up there, he thought I was the greatest radiologist when he talked to anybody in Michigan, you know, and he was on the board. And just as soon as I showed an indication that I might possibly move, that's it. Well, it was a fortunate thing because it released me from the responsibility of Flint, and Joe was going to leave within a week or two. So I came on down, and that was in December, or at least in the fall of '49. So then in '50, Spencer Hilton came down, and he actually was the first resident in radiology. Now, he wasn't here the full time. But he completed, and then the first full-time resident we had was the name of Sutherland. And he finished here, and then he went on. So it went. We developed quite a large group of residents coming and going. And in the meantime, this thing was growing and growing, and I needed assistance. And so I contacted Dr. Baudet. And Baudet came down then, and we were associated. In the process of training residents, there was a Dr. Conway, which I'm sure you all remember. And so this was been about in the late 50s, because I relate this. In the meantime, the X-ray department, we had taken over just about all the space we could down in the basement. And we were operating the outpatient department from 7 in the morning to 11 at night, and we still weren't doing the job. We needed room. Well, in the meantime, Dr. Elliott was building a building over on Salem Avenue. And he talked to me about putting an X-ray unit over there. And it seemed to me that that would be the logical thing to do. Now, Dr. Baudet and I together were going to do this. Because we couldn't take care of the outpatient service here. Well, that wasn't very well accepted, so I presented it to the board that this X-ray department was going to be there, and if the hospital felt that this was an imposition on their business, I was willing to let the hospital take over that department and operate it as an outpatient department. We needed it badly. Well, I might just go up and talk to the wall. That went over like a brick. So from that time on, I resigned from the department, and Dr. Baudet took over. And as you know, eventually Forrest Neal X-ray took over and that sort of thing. But we grew, and it's like all the other people in their departments. You were constantly up against problems of growth. And this is the only way I could see that I could provide a service for the profession that the hospital wasn't capable of doing. Well, I was a bad boy, I guess, in the whole process. But I think it came out reasonably well. So that's sort of the history of the Department of Radiology. It's gone on to develop into, I think, a very complete radiology department. Of course, radiology has expanded so much that there now is subdivisions. You have either you're a therapist or you're a diagnostic. You could be in all kinds of subdivisions of diagnosis. So this is the growth of radiology as a whole and in the department here at Grandview.
If I may, Roger Bennett again, giving you the history of the anesthesia department. I came here in '41 looking for a place to practice, and they advised me that Dr. Walker took care of things here, and but there was an opening in Middletown where a DO had recently died, and they were looking for someone to take over his office. So I went down there and made a deal and took over the office there in Middletown. And then I continued. Dr. Sugar was having trouble getting coverage in his anesthesia, so I agreed to do some work for Dr. Sugar. Not for Dilettosh, he didn't care for me. And so that created some strain. But finally it blew up with a case that didn't go very well, and I went down and told Cornwall they were paying me $450 a month to cover the anesthesia, which I was permitted to do, but Dilettosh wouldn't give me any work. Finally, I told Cornwall it was a rip-off of the hospital to pay me for work that I wasn't able to do, and I subsequently quit as of that time. Well, they had to have someone else, so Carl Gephardt wasn't too busy. Things weren't real hip to do in private practice at that time. So he went to Philadelphia for a couple of weeks and got, at that time, pentothal anesthesia was just breaking into the scene, and Carl got some training in that and also some blocking techniques, and carried on for a long number of years very well in the anesthesia department. But I finished I was the first resident to be put on the board up there at DOH as being trained there. I left before I was fully trained. But, that's the story on the anesthesia up to Gephardt's period of time.
I'd like to, you're through, writing?
Well, I think I should quit.
Well, I just wanted to read Dr. Elliott's he describes this as Grandview History, Personal Observations and Recollections by Dr. Elliott. And of course, he brings up some names in there that I think you'll all recall, and maybe bring even some other things to mind, because I was very pleased when I received this from him. And some interesting aspects. And Jim says, in June 1950, I arrived in Dayton, Ohio to begin my journey of my professional life. I had graduated the week before from the Philadelphia College of Osteopathy, stopped in Columbus to take state boards on my way to 405 Grand Avenue, which is Grandview Hospital's address. I had asked permission to start July 1st, but Dr. Gephardt, who was anesthesiologist and chairman of the intern committee at that time, wrote to me telling me that my services were urgently needed and to get here to Grandview pronto. Grandview had just moved to Grand Avenue from 2nd Street the year before and only recently opened the obstetrics unit. Upon my arrival, I finally was directed to Mr. Back, who was the administrator, and after a 3-hour wait, I was asked into his office. You know, all of those that have been around here, you all can empathize with this sort of thing. Much to my chagrin, he wasn't expecting me, and there was no place for me to stay. I lived out of my car for 2 weeks with no assigned duties and just waiting to be told where to go and what to do. Now here's a name that none of us have mentioned, but it's very prominent with all of us actually. Fortunately, I was engaged to Dr. Glenn Snyder's daughter. Remember Glenn Snyder?
Oh, yeah.
And was able to sleep in my Amherstburg at the Snyder residence. After a week, I was issued a pair of white pants, a white T-shirt, and assigned to the emergency room, just like you were talking about. There was no indoctrination. The first patient I saw was a young boy brought in by ambulance from around Greenville. He had dived into a shallow pond and broke his neck. Dr. Bradford was walking by and came to my rescue. Needless to say, I needed his help. After another week, Mr. Back rented a room at Mrs. Ferris's rooming house on Grafton Avenue for Dr. Herb Javery, remember Javery? For Dr. Herb Javery and me. Other interns include Art Dannon, Otto Masick, and Jake Krause. After a month, Virgil Hawes joined us. These were interns at that time. At that time, graduation dates were at different times of the year due to the wartime changes, and hence the different starting dates. Interns received $75 per month in those days. Actually, that wasn't too bad considering what some other programs paid. The days were long and lectures were few, if any. We were rotated, excuse me, we were rotated on services, but that was nominal. We were in surgery. You remember the internship was not structured very much. Dr. Quinlivan was a big help, and he tried to teach us, especially when we were actually on surgical service. Night calls were rotated, and that meant being on full duty all day, and then all night, and then the next day. We had to cover the emergency room with no attending signs. If we wanted to have a stat blood count, we did it ourselves. If we wanted to give blood, we had to do the cross match, and if we wanted an x-ray at night, we did that too. Kind of scary at the time, and worse as I look back on it. The night intern had to draw all of the blood for lab procedures for routine lab orders the next day. If we got any significant lectures, they were not impressive enough to remember. We did, however, get a lot of experience. The OB service was very active in those days. Besides Doctors Haas, Gephardt, John Robert Snyder practicing as a specialty, most of the GPs delivered babies. Dr. Donald Levitt was very busy with general practice and with deliveries. He delivered all 5 of my children over a few years' time. As interns, we did get to deliver quite a few babies, mostly with supervision. Dr. Germanovich, there's another name we haven't mentioned. Dr. Germanovich was good about teaching us to sew up episiotomy. Occasionally, Dr. John Robert Snyder would show us something if he was in a good mood. And I know all those who knew all these people, you recognize the character implications there. I remember there was an English nurse, and I remember her, but I don't remember her name either. He says, I can't remember her name, that had lots of maternity experience in England during the war. Her daughter Myra was a nurse there in OB also. The mother was a big help to the interns. She taught us a lot about doing rectal exams and when a patient should go into the delivery room. So you learn a lot from nurses. One obstetrical experience was most outstanding. A baby was about to come, and we were taking the patient into the delivery room. Her mother wanted to go in too, and when I tried to stop her, she hit me in the mouth and broke my tooth. I still have a crown on my left central incisor as a memoir. The only dental work I ever had after that was paid for by the Industrial Commission. In November of 1950, Ohio State and Michigan played their annual football game in Columbus. It's 1950. Jeez. Many of the staff attended the game that year. The thing about 1950 was that it started snowing during the game and snowed a foot or more of snow in Dayton. It was windy, so there were some awesome drifts adding to the problems. Many of the travelers were stranded between Columbus and Dayton. Some even had to sleep in farmhouses. Dr. Gephardt was one of the lucky ones that got stranded. Dr. Barney Herbert and I were stranded in the hospital, along with Dr. Whitey Williams of Lebanon. We delivered babies, pronounced people dead, and did much of the day-to-day work. It was a couple of days before things got to moving, and other physicians could get in and out of the hospital. The police took Dr. Georgiana Harris to deliver a baby at home and to see some other patients. As interns, we complained like all interns do. Our complaints centered around no lectures, having to sleep on a mattress on the floor in the orthopedic room when we were on night call, and having the same food to eat at noon, evening, and late at night. Being called from one service to go help in surgery. Surgery in those days was different than now. The operating room was at the back of the hospital on a corridor that ran parallel to Shaw Avenue. There was no air conditioning, and the windows were open with screens. One could talk to the physicians as they were walking by coming to the hospital. The emergency room was in the first room on the right after entering the operating room corridor. One could walk the hall back to the OR, stand in the door, and talk to the surgeon with any problem. The drapes and the scrubs were white, and the scrub technique was 10 minutes of scrub with bichloride of mercury and an alcohol rinse. Later it became Physohex, and later betadine appeared. Anesthesia was varied with open drop and later closed circuit ether. Chloroform was still in use. One-shot spinal anesthesia was often used, and if it didn't last until the operation was over, there was much excitement to convert to another anesthesia, as Roger will tell you. Of course, there was much pentothal and curare as well as nitrous oxide. The kids were given rectal pentothal in the room and then open drop ether. In those days, TNAs were plentiful. The anesthesia charge for TNA was $10. Now I don't remember. I read this before, but I don't remember. But Dr. Levine, Dr. Elliott, and myself were involved in an operating room explosion. You remember that? Yeah, I'll elaborate on that. He may have mentioned, because it was Dr. Elliott's patient whose chest blew away. After about a year, the hospital purchased an old house behind the hospital that became intern quarters. I believe that Hugh Townsley's class was first to use the new quarters. I recall Glenn Sickinger and Paul Panakis were also in that class. After the first of the year, I applied for surgical residency. Herb Javery also applied. Bill Quinlivan was instrumental in helping encourage me to try for the slot. I was lucky and was accepted. Herb changed his goals and applied for anesthesia residency and was accepted. Bill Quinlivan wasn't done till the next spring after I started in the summer of '51. I finished my residency in 1952. The residency actually was an endurance record. On call every night and every weekend, essentially. In those days, general surgery did all the C-section, all the DNC. The residency covered the waterfront, including orthopedics, rectal surgery, urology, and almost anything that came on the floor at day or night. At first, there weren't any medical residents, so that made the surgical resident the only one available above the intern level. The pay was $100 per month and no moonlighting of any type, as Everett Wilson found out later when he was in his ophthalmology residence. If caught doing any kind of remunerated work, expulsion was the threat. Medical care was different in those days than we know it now. Bill and I were ecstatic when the hospital purchased a flame photometer that enabled us to get electrolyte results the same day instead of the day following. Stat electrolytes were an impossibility. As residents, we were allowed and encouraged to take care of our own post-op care, and that was one of the good points of the program. Earlier, I mentioned the lack of air conditioning in the OR, nor was it available on the floors either. This added to the fluid and electrolyte problems with sweat loss, often very significant. Oxygen was administered by tent, air conditioning of a sort. The day of plastic tubing was yet to come. The first use of polyethylene tubing was on Louis Hursting's daughter. Dr. Doblai did a cut down to insert the tubing. There were many interesting anecdotes during the residency. One such instance was when someone put formula down the balloon side of a Miller Abbott tube on a patient of Dr. Doblai's. The patient was oriental and ultimately had to be taken to surgery to remove the offending obstruction. For a minute, this oriental was the chef down at the Chinese restaurant that was below Old King Cole. Other residency obligations I inherited, including exchange transfusion on babies at the request of Dr. Jarrett, and Jim has put request in parentheses. Autopsies that our itinerant pathologist, Dr. Dilley, would not do. Remember Dr. Dilley? Anything that might be a coroner's case that the coroner wouldn't do, Dr. Dilley refused. I remember doing an autopsy in the wee hours of the morning one time. I was alone with the corpse working when Otto Masick stopped by, and he says, "What did he die of, Jim? Anything serious?"
Could I interrupt this a moment
Yes,
so I don't
please.
forget this? In the same autopsy room, I was down there one night watching cases. It was when I was still in practice. Anyway, Billy was doing the post, he said to the resident who was helping, he said, hand me that bucket there in front of us, a bucket with a board over the top of it. And he picked up the bucket, and I saw the resident kind of go back and held it up, and Dilly said, where did that come from? It was a head, a human head in this bucket. And come to find out that Jack Miller was in Kirksville, and he bought it for his own personal use. But he kept it down the morgue.
Grandview originally started on West 2nd Street in an old home. It was known as Dayton Osteopathic Hospital for most of the time until 1948 when it moved to Grand Avenue. Many of the physicians thought it very foolish to buy all that property. In 1949, the OB wing opened, making the hospital 90 beds. The hospital was started by Dr. Gravis, Dr. Dilatosh, Dr. Ebert Dill, who was Dr. Dilatosh's brother-in-law. Dr. Frank still had an office in Lebanon and commuted when surgery was to be done. Dr. Dill would call Dr. Frank and tell him to bring his tools to do some procedure. The support of the hospital was different in those days. All of the DOs from surrounding towns sent their work to the hospital. There was Abe Simon in Troy. Any of you know Abe Simon?
Yeah,
Dr. Smalley, Dr. Jacoby, Dr. Glenn Snyder in Miamisburg, Dr. Whitey Williams, Dr. Ralph Young in Lebanon, Dr. Frank Krumholtz in Springfield, Dr. Fred Swope in Richmond, Dr. Dave Seal in Sydney, Dr. George Basower in Franklin, Dr. Paul Charis in Greenville, Dr. Robert Neff in Troy, Dr. Miles Germanovich in New Carlisle, Dr. Thompson in Middletown, Earl Wright in Waynesville, and Bob Berger in Germantown, as well as the old-timers in Dayton. These included Emerson Early, John Aliff, Georgiana Harris, Herb Ranier, Harry Cosner and his father, E.H. Cosner, George Guston, Don Levitt, Fred Bossmeyer, Leo and Louis Hursting, Paul Brenner, and probably a few others I can't remember. While part of this allegiance might have been fee splitting and the fact that the MDs were not friendly, a lot of it was osteopathic loyalty. In 1953, fee splitting came to a sudden halt. The IRS visited, now this is something I did not know, the IRS visited Dr. Dilatosh and disallowed monies reimbursed to GPs. Further, they explained to him that they would be back the following year, and if there's any evidence of fee splitting, charges would be placed against him. Further, the state of Ohio had enacted statutes that prevented fee splitting under any guise whatsoever. The federal government enacted the same type of legislation a year later when Medicare was passed. This did not end the support of the hospital. Most of the family doctors came to the hospital and made rounds, scrubbed on surgery as assistants, and continued using Grandview. During the 50s, the physicians that interned at Grandview stayed in the area in great numbers. Most found areas in the surrounding towns. Dr. Sechinger and Townsley stayed in the area. Dr. Richard Seal went to Eaton. He was so busy that once the police stopped to question a person at about 11 o'clock as they were about to enter Richard's office, they had an appointment. Dr. DeBard went to Centerville, Dr. Murphy to Beaver Creek, Dr. Benson to Middletown, Dr. Bach and Dr. Lederman stayed in town. Russell Field went to Farmersville, and his twin brother Nick went to Camden. Paul Seal was in New Paris, and Lloyd Carroll was in New Paris, and Dick Cheney in El Dorado. John Vossler and Ferguson went to Preble County, and Cliff Levitt to Morrow. I think now, how many of those, I don't know if any of those guys are even in practice anymore. The staff grew rapidly, and so did the need for beds. See, and something I think no one appreciates today is that at that time, here we have an abundance of beds, an overabundance of beds today. In those days, patients were waiting 2 or 3 and 4 weeks to get into the hospital. A new multi-story building went up in front of the original, and then a 2-story OB gen addition to the west. A meeting hall in the ground level was named Dilatosh Hall. This multi-purpose room was adequate for staff meetings, educational meetings, and committee meetings. Later, another addition was built to the east of the main building, and later on, an extended care facility at Shaw Forest was connected by a tunnel. Before this, the old intern quarters behind the hospital was torn down and a laundry was built. Grandview always did their laundry in-house. Ann Drescher was in charge, and the laundry grew with the hospital. This was a unique feature of Grandview. Later, a parking garage was added west of the laundry. When Dr. Quinlan finished his residency, he stayed on. He wasn't welcomed with open arms. Some of the surgeons didn't even want him to be able to accept referred work and didn't want him to have privileges in such things as hysterectomies and thyroidectomies. Fortunately, a new era was born. Bill received his privileges in open practice on Salem Avenue. Later was invited to join Dr. Dilatosh in practice downtown. Before I continue with this story, I'll tell you a little about the history of surgery at Grandview as told me by Dr. Dilatosh and confirmed by Dr. Snyder and Herb Bernier. In the beginning, Dr. Dilatosh got what training he had from A.C. Johnson. A.C. Johnson was an excellent surgeon from Detroit Osteopathic Hospital, and Dr. Frank learned the basics. Later, Dr. Schubert had about 9 months training in surgery at Kansas City after his internship. He joined the staff in competition with Dr. Dilatosh. Later in the 40s, Dr. Dilatosh wanted to start a training program. It was 2 years and cost the trainees $1,000 each. Also, the trainee had to take a basic science course on his own expense and for at least 100 hours. The course that was designed for this was at the Osteopathic School in Los Angeles. It was too expensive and lasted 2 or 3 weeks. Dr. Dilatosh wanted Dr. Gephardt to take the course, but he was interested more in anesthesia and didn't think the time and expense would be worth it. Dr. Zimmerman wanted the course, but Dr. Dilatosh convinced Dr. Dobolite to take it. Dr. Dobolite had worked for the hospital and for a time moonlighted at Delco to make ends meet. He also had some general practice. Dr. Zimmerman went into internal medicine. Dr. Henry Shade had an abbreviated internship and surgical training because of wartime exceptions. He trained with Dr. Ballinger in Toledo. He did general practice in Moraine City and did a modest amount of basic surgery on his own patients. Drs. Adams and Croushore both took the 2-year preceptor and each had a general practice. Dr. Croushore had done his internship in Lancaster, Pennsylvania. At any rate, both stayed on and basically did no referred work but did surgery on their own patients. The preceptorship program was then abandoned and became a 3-year full-time residency. Dr. John Robert Snyder applied for, but Dr. Quinlevin was accepted. He had graduated from PCO in Philadelphia and had his internship there. Following this, he practiced in Syracuse, New York. He started his residency in the spring of 1949. He was the first resident. I became second resident, but was to do my internship at Grandview. Residents to follow me included Dr. Lester Hoberstein. Everybody remember Dr. Lester Hoberstein of the Sam Shepard fame? Yeah.
In relation to that, may I interrupt for a second?
Yeah, please do.
Dr. Johnson came from Cleveland Clinic to DOH and brought Axelrod with him, his anesthesiologist. He was working in Shepherd's Cleveland Clinic when he went to DOH. That's all. I just wanted to skip that in.
Residents to follow me included Dr. Lester Hoberstein, but he never finished. He was followed by Dr. Eugene Ackley, Neil Caldwell, and Sparrows Gabriel. After I finished the program, I stayed on and opened my office at Salem Avenue. I did only surgery with no general practice, but I did do some obstetrics, but mostly cesarean section. I did deliver a daughter for John and Mary Bossler, another for Tom and Carlene Seal, and another for Don and Susan Seal. There were other deliveries for staff doctors. In fact, when Mary Hursting was in labor with her last child, Bill Quinlan and I were visiting her and ended up delivering the baby on the spot. Anything he puts on here, anything for a friend. After a year, about a year after I finished, Jack Adams took off 6 months to get additional training in urology, which he was very interested. Charlie Cornbrooks, who was an intern at that time, finished his internship at Grandview and covered Jack while he was gone. And I remember Charlie threw several real good parties in Jack's house while he was away. After Jack returned, he limited his practice to urology and gave up all general practice. Charlie moved to Darien, Connecticut to practice. Soon after this, Paul Croushore did a similar thing, except he took training in vascular surgery with Dr. Costello in Los Angeles. I believe that Jack Evans did his urology with Dr. Scouten in Kansas City. The department matured rapidly in the middle 50s. Dr. Dager and Dr. Louis Hursting gave up general practice and did proctology. For the most part, the general surgeons gave up proctology and urology. Dr. Quinlan and I gradually expanded the field of general surgery by going into various clinics and courses and bringing things back. we did the first radical hysterectomy for cervical carcinoma. This was on a patient, Dr. Townsley's, that had a recurrence of the carcinoma after initial radiation. From that, my gyn practice grew, and within a few years, we had done more than 50 radical hysterectomies without a death. Well, in 1958, Dr. Quinlan and I started doing combined synchronous abdominal perineal resection. The first one was on Bruce Middlestetter. It took 35 minutes instead of the usual 2 or 3 hours. Even though he had nodal metastasis, he did well, and Dr. Hetzel reoperated him many years later for hernia when he was in his 80s. Getting started in surgery was not easy at Grandview. There was a matter of a $5,000 cash fee for getting privileges. As I remembered, it was 10, but maybe it was 5. We had to buy all our own instruments, and then, of course, there was a matter of service charges. These had to be current or we were suspended. I remember one instance in which Mr. Back came back to surgery and stood in front of the OR door and wouldn't let Dr. Bradford in to do surgery until Bradford gave him a check. During my residency, we scrubbed on anything and everything. Dr. Hours started as the first orthopedic resident when I was in my 2nd year. Dr. Seal had come from Kirksville, where he had been teaching, and joined Bradford. Following the residency started. I used to cover orthopedics when Dr. Seal and Bradford were out of town. With Fred there, it wasn't bad. I was happy when Fred finished and my services were no longer needed. Dr. Bradford was known locally for more than orthopedics. He was an owner or part owner of a minor league ball team in Dayton. I think it was a farm team for the Cleveland Indians. I remember seeing Minnie Minosa and once Ted Kluszewski when they played an exhibition game with Cincinnati. There were a lot of fun things in the 50s. There were excursions by train and later by bus to see the Cincinnati Redlegs at night. A little drinking and craps on the way, and sometimes on the way home. Once Dick Kenny, remember Dick? Once Dick Kenny fell asleep in the back of the bus and didn't wake up until long after the game. We had golf tournaments that ended up in a party house down by West Carrollton in the woods. After the golf, there were some baseball games at times. Good food, lots of prizes, donated by the drug reps, and cards and craps afterwards. Once or twice, there were some censored movies. Luckily, we weren't rated. The most memorable was a lobster clam bake thought up by Wes Bodette. A lot of the guys drank too much clam juice. When Gabriel got home, when Spiro's Gabriel got home early, Phyllis wanted to know what was wrong. He had wrecked his car. Around 1955, Bill Quinlan took Lodge Beck's course in cardiac resuscitation by open cardiac massage. Bill and I thought we would share the training with the surgical staff. Jim actually went up there with me. We had maintenance build some steps so everybody could see the OR table. Gabriel was a resident. We sent him to the dog pound to get a dog. They talked him into taking a beautiful Dalmatian because he didn't dare tell them what it was for. Naturally, he couldn't tell what the dog was for. Herb Javery had been a veterinarian before osteopathic school, and he had also finished his anesthesia residency. So he volunteered to anesthetize the dog. The dog was fibrillated, shocked, resuscitated, and everyone had a hand in the training. We later repeated the training in Dilettush Hall for other members of the staff on 2 or 3 occasions. Needless to say, however, no more Dalmatians. That was the first step to our having a patient. That was the first steps to having patients survive cardiac arrest. As the time went on, we gradually expanded our surgical endeavors to include diaphragmatic hernia repairs, more extensive gastrointestinal surgery, and pancreatic surgery, including Whipple operation. Thanks to Tom Jarrett, who had quit general practice to take a pediatric residency at Des Moines, we had a rather broad field of pediatric surgery. A lot of people here today don't realize at one time we did a lot of pediatric care, a lot of pediatric surgery. Tom developed the pediatric department to a very busy area with great success. Under his guidance, a pediatric residency was started, and his early residents included Tom Harden, Neil Cantor, Ben Cohen, and others. Then he goes on to tell about when I went to Grant. Bill was active in college search and was on the board of governors. Through Bill, I was appointed to ACOS Residency Evaluating Committee. At the same time, I became active doing intern and residency inspections for the AOA with Don Seal. Don was very active in the political side of the profession, rising to president of the presidency of the OOA, the AOA, and the ACOS, and Academy of Orthopedics, and just about every other organization in our profession. Don was a great ally, and helped me to accomplish many things through the ACOS residency, the evaluating committee, and the AOA committee on postdoctoral training. Eventually, I spent 25 years working on these committees, being chairman at times. Dr. Wes Boudet was also active on the AOA on the college of postdoctoral training, on the committee of postdoctoral training, helping to establish training standards in the early days. I was also fortunate enough to follow the lead of Dr. Quinlivan, who was a few years on the Board of Governors, and actually being president of ACOS in 1981. Dr. Hugh Townsley was president of the Dayton District Academy in 1957. He was our representative on a steering committee to form the Dayton Hospital Planning Board. I followed Hugh as president of the Academy in 1958 and became a member of the Permanent Hospital Planning Council that grew out of the steering committee. Before that time, any hospital that wanted to build an addition had a public drive to raise money. Since everybody wanted to get into the act, it got out of hand and a moratorium was called. The Planning Council then had to approve any request for any additional facilities, and that was the forerunner of the present certificate of need. Actually, the City Planning Committee was to ultimately become the Southwest Ohio Regional Health Planning Board. By virtue of the fact that I was a founding member, I became a member of the Executive Committee and enjoyed working with community leaders such as Fred Wright, Stan Lang, NCR President, and Herb Lehman, Vice President, General Motors, who was chairman of the committee. We were the first health planning committee in the United States to have a trained executive director. Efforts were made to secure a thoracic surgeon to expand our surgical staff and provide the service that was badly needed. After a number of years, it seemed that to fill the void, I would have to get the training. I called Bill Bradway, a DO surgeon in Columbus with thoracic training. Much to my eternal gratitude, he agreed to set up a 2-year informal fellowship program so I could qualify. That was in 1965. He came to Grandview Hospital for all thoracic cases, and I traveled to doctors for all of his thoracic cases. In addition, Bill Bradway had outlined a series of accomplishments I must do, which included a dissection course at Ohio State University, a tutorial course in chest film by Dr. Jim Fox, bronchoesophagology at Temple University, and then rotations with Dr. Overholtz in Boston, in addition to reading programs. Progress is never easy as it seems. By 1964, intensive care units were starting to become commonplace in hospitals. With all of the heavy surgery we were doing, such as neurosurgery, pancreatic resection, esophageal resection, and heavy gastrointestinal surgery, it was apparent that Grandview had a need. This was addressed by me in a letter to Mr. Beck. That's the one I referred you to. This issue had been discussed before, and the concept had been adopted at a special staff committee that met at the Holiday Inn north of Cincinnati on December 7th and 8th of 1963. However, the administration took no action. After the letter in 1964, we brought it up at the Department of Surgery. Following that, Dr. Quinlivan and I started a letter campaign every time we had a patient that we could have used the service. We wrote both to Joe Back and to Don Wood. Everybody here remember Don Wood was head of our president of our board, president of the board of ODs. Yeah. After several months of laying it on the line in their laps, Don told Joe to get these guys off my back. With that, Mr. Back gave us room 204 and 206 in the corner of the second floor. This was in 1966. He refused to give us a phone, however. The desk was in the hall. That was our humble beginning with an ICU. It worked. We not only got the phone after a few months, the unit expanded, and when we built the addition on the north side, we were included with a 9-bed unit adjacent to recovery room. Persistence pays, and Pat J. was our first ICU nurse. Many times progress doesn't come easily. For instance, we used to all dictate and transcribe all of our operative reports and case summaries in our office. We had been after administration to give us a central dictating system. Finally, in 1967, when one of the building programs was getting started, I contacted many of the doctors. I figured if each doctor would give $100, we could raise half of the $6,000 central dictating system would cost. I had researched this to determine the cost. Next, I went to the architect to see if he could get it in the plans, and finally went to Mr. Beck and told him I would raise half the money if the hospital would provide the rest. He never knew that all of the planning had been done. However, fortunately, he bought the deal and we got the system. Another similar incident occurred around 1966 to 67. I was doing quite a bit of pulmonary work by then, and Don Burns had finished his internal medicine residency and was very interested in pulmonary medicine. We wanted a blood gas machine, but got nowhere with the administration. Through the help of Charlie Hoysh, remember Charlie Hoysh, the lab director, we got a salesman to sell us a machine which was promised to a hospital in Greenville. The equipment was much in demand as the new field developed. We paid $2,200 for the unit. The hospital had $25,000 in charges the first 6 months. That was with only 2 of us knowing about blood gases in the beginning. Now everybody knows. Is that true, Doug? Yes, true. Well, these are just a few of my recollections. I have more, and we'll work on putting them on paper before my memory fails me. It may end up like my sister, though. I once told her that her memory was so good that she could remember things that never happened. And in closing, he says, I do recall another cute anecdote. Bill Quinlevin's mother was visiting, and a Grandview truck was parked out back. When she saw it, she said, really, Bill, you would think the hospital could afford a better-looking ambulance. I thought it was
That's quite a
good writing.
review.
You've got a review, yeah.
That's excellent.
That blood gas machine, Joe Back, we were trying to get it, it's something terrible. And Joe Back thought it'd just never pay for itself, so Jim and I put our money together and bought the blood gas machine, paid for itself in about 2 weeks.
Yeah.
It was $2,200 if he's right. And I just put one into the budget for this year for $39,000. So it's gone up a little in price.
And much more sophistication, of course.
Oh, yeah.
Would you continue with talking about the development of respiratory therapy?
Yes, I'm Don Burns, and I first had something to do with respiratory therapy. I worked here as an orderly at night in about 1950, and at that time there wasn't such thing as respiratory therapy departments or inhalation therapy departments, and it was largely oxygen tents which we had, which I don't really know who they were under. I presume nursing, administratively they were under. But anyway, I would go around at night and fill the oxygen tent with ice and have to roll the tanks up. Of course, we weren't piped for oxygen at that time, and roll the tanks around and so forth. And that was a good job. I'd, in fact, go downtown and at night sometimes have to buy ice and put it back in my car and drive it up here, and then with an ice pick and so forth, break it up so we get it into the oxygen tanks. And I remember the nursing supervisor then, who I can't remember her name, but she would give me a $5 bill or something and send me downtown for ice. But anyway, the actual Department of Inhalation Therapy started here in 1963, and I was a medical resident at that time, and inhalation therapy departments were just getting started around. There were very few in Ohio at that time. The Kettering Hospital happened to have one, and it was because of the fact that Eugene Kettering had emphysema, and so he poured all sorts of money into the pulmonary department at Kettering Hospital. But and I think we were the second in this area to have a respiratory therapy department. And at that time, Yvonne Short, who was an RN, was the lady who was over the respiratory therapy department, and was in a closet downstairs that was probably about 4 feet wide by 8 feet long. And I remember there was a big bathtub in this closet, and there were oxygen tents hanging over the bathtub, and a secretary sitting at the end of the bathtub where she did her typing. And the bathtub is where we sterilized things. We put various chemicals, ceticide and that sort of thing in there to sterilize the equipment. And you'd walk into that area and your eyes would burn and so forth. The secretary would sit there all day long and type. So I don't quite know how she did that. But then in 1965, actually, it was Jim Fox that got me interested in pulmonary medicine to start with. I was a resident, and I was down there one day looking at x-rays, and Jim said, well, why don't you think about pulmonary medicine? He said, nobody knows anything about lungs. So that got me interested, and I went to a course up in Chicago, a 10-day course, and after that I thought it was just greater cotton candy and respiratory. So in 1965, I felt that we should beef up our inhalation therapy department some. And I went down and talked to Joe Back about it, and he said he figured I knew about much about as anybody around here. And by then Herb Jabry, decided that he wanted to do that. Now, Herb, I'm not sure whether he bought the first IPPD machine here. I don't think he bought it. I think the hospital bought it. It was Dr. Jabry's machine. If you wanted an IPPV on a patient, you had to get permission from Dr. Jabry to use his machine. Well, that just burned the Department of Medicine no end to have to get permission from the anesthesiologist to give an IPPV. So Dr. Jabry applied for this position, and I applied for it, and Joe Back was kind of pushing me, and I don't really know why, but anyway, it ended after I got that position, so we started from there. And right after that, this old IPPV machine was a Mark 7, Bird Mark 7, which you could use as a ventilator. It was a pressure cycled ventilator, and we started putting patients on this pressure cycled ventilator back then. And to my knowledge, we didn't have anybody live. I never saw anybody live on the pressure cycled ventilator. There were some reports of people living in the literature, but we didn't have any. And then in '65, soon thereafter, we bought the first volume cycle ventilator, the MA1, Bennett MA1 ventilator. None of us knew how to use the thing, of course, and so we read a lot and played with it a lot and so forth down in the basement. And so we finally got the thing set up, and then we started using it, and we were quite successful with it. Really, it was the only ventilator which we had at that time. About the same time, or shortly thereafter, we saw a need for a pulmonary function laboratory, and Jim Elliott and I worked together quite a bit on this sort of thing because he was interested in thoracic surgery, and I was interested in pulmonary medicine. And he also felt the need for a pulmonary function lab. So we went to Joe Back again about buying some pulmonary function equipment. Well, Joe didn't feel it ever paid for itself. So Jim and I found that Doctor's Hospital in Columbus had an old water spirometer up there, which I have no idea where it came from. It hadn't been used. They said they'd be glad to sell it to us for $20. So Jim has Apache, we did some flying then. And so we flew to Columbus, and Doctor delivered this barometer out to the airport for us. And here, lo and behold, we hadn't looked at it. We bought it sight unseen. And I think we got done in with our $20 because it was rusty and it was just a terrible mess. So we brought it home and looked it over. We ended up sending it back to Cambridge in Massachusetts, and they completely redid it. It took about a year to do this. But then we had the pulmonary function laboratory, and the remnants of a pulmonary function laboratory. So once we got it going, needless to say, it paid for itself pretty rapidly also. But it wasn't too long after that. Systems Research Laboratory was here in Dayton, and they did a lot of military work, and they were the first, one of the first companies who actually made electronic type pulmonary function equipment, not water sealed spirometers and so forth, but electronic. And so we bought, I think it was the third unit which they made here in Dayton, and we bought it here. It was really state of the art at that time. And and it also paid for itself fairly rapidly. But and then we got into the business. We bought the blood gas machine. Blood gases were first done in the laboratory, and then after we got our pulmonary function lab going well, I talked Alvarado into letting us in respiratory take over doing blood gases. And this was kind of I caught it from everywhere when we did that, because in Dayton, the doctors were all drawing the arterial blood gases. They didn't let nurses do it. They didn't let anybody else do it. Well, I happened to go to a hospital, Edgewater Hospital in Chicago, where one of the most progressive inhalation therapy departments in the country, was at that time. And there, the medical director of that department felt very strongly that respiratory therapists should draw blood gases, should do the arterial sticks, should be able to do the blood gases. And at that time, which was really a far-looking thing, we're doing it now, but they actually made adjustments on ventilators and so forth. The respiratory therapists did. And so we came back, trained our respiratory therapists to do blood gases. Well, the people of Miami Valley were on me, and the people of Kettering were on me, and so forth, that I was absolutely promoting malpractice over here and having respiratory therapists draw blood gases. And there's still some question about it. I think in Miami Valley, still the nurses draw most of the gases over there. I don't know. Do you know, Jim?
I think they're tax drawn.
Are they doing it now? For a long time, after they quit having the doctors do it, then the nurses do it. But so our people then drew blood gas. At this time, most respiratory therapists were on-job trained. We trained our own respiratory therapists, and it was our thinking then that education was the backbone of having a good department of respiratory therapy, and so we tried to get away as much as possible from on-job training for respiratory therapy. And about the same time, Sinclair was setting up a respiratory therapy school, and so we affiliated with Sinclair from the education standpoint, and we trained respiratory therapists here to rotate through. Our goal was to have all registered and all certified therapists, and that was kind of a far-reaching goal at that time also. Now, of course, we have all certified, and they're licensed and the whole works at the present time. But we did put a lot of emphasis on education. We ran education programs for respiratory therapists. We had one respiratory therapist who did nothing but was in charge of education for our department. And I think by doing this, Grandview really had one of the best departments in the state, the respiratory therapy departments. After Yvonne Short, going back to 1963 up to 65, she was in a bad auto accident, and we had a lady in here called, her name was Liz Green, and she had been head of respiratory therapy at Children's Hospital here in town. She was a registered therapist. She was the only registered therapist we had at that time. So she was here a few years, and she moved to Florida. And Frank Highlander, I don't know if you'll remember him or not, but Frank was head of the pulmonary function laboratory out of Wright-Patterson. And he was retiring from the Air Force about then. And so we brought him here. He headed up our pulmonary function laboratory and ended up being technical director of the whole thing. He was there about 20 years. And then Frank had some heart problems and such. And Dale Bortz is now head of our respiratory therapy department. In 1977, going through the respiratory therapy development, we established a pulmonary rehabilitation department down at the old ACC, Southview. And that was a rather new thing at that time. There wasn't too much about it. We had terrible problems getting insurance to pay for it and such, but it seemed like a very good thing. Dr. Tom Petty, University of Colorado, was doing a lot with the early days of pulmonary rehab, and so we got the pulmonary rehabilitation program going. Jerry O'Ryan, who was technical director at the ACC then, there wasn't anything written particularly on pulmonary rehabilitation, so Jerry and I got together and we wrote a book on pulmonary rehabilitation, which gave Grandview a fair amount of publicity. It's printed in Asia and Europe. It's used quite a bit in Europe still, and it's been a textbook for respiratory therapists, largely. And so the pulmonary rehab has been a big thing since 1977 in respiratory. In '79, going ahead and enlarging our department, sleep abnormalities were becoming seemed to be important in the health of people, And so we established a sleep lab at the CC and started with that in 1979 and gone on up through the present. In feeling toward education as being primary in delivering good care, in 1980 we established the pulmonary fellowship. And in fact, I think I'm fairly certain we were the first fellowship in the hospital here in pulmonary. Since that time, we've trained, I guess, 9 fellows in pulmonary medicine. And Dr. Bellis was the first fellow we had. So that's pretty much the history of our department. It started out with oxygen tents with the ice in them, and then we gradually expanded, and now, unfortunately, I think we're going the other way with the new change in the way of delivering medicine. It's a real challenge of how we approach it now. Unfortunately, I think quality of care has suffered some, but we're certainly looking for new ways of improving care under present constraints.
That's very interesting.
My turn?
Your turn.
I guess so. I'm Dr. Dager. I am a proctologist, and I want to thank Dr. Kraus for having this meeting, although he's not here at the moment. But as I look around, I see that I am not the youngest person here. So my memory goes back to DOH in the old building. And I wrote down a few things that I remember. And then I would like to kind of go into our own department. I remember the old building. It was a stately building, well built and clean. I remember the kitchen help strike. And our wives took over for a few days. We cooked the meals, we served the meals, we did the kitchen work. I remember the furnace failure. And a temporary boiler was stationed in the alley outside the DOH. We had a big boiler set up in the alley because, of course, we needed heat. I remember the progressive laundry fire. Our surgical drapes and linens were destroyed. Everything was sent to the progressive laundry. All laundry was sent there. And I remember hiring a part-time administrator, Bill Knoll. And I remember that he would come in maybe twice a week, and we would consult with him, and we would offer our suggestions or complaints. And I remember the General Motors gift of $110,000. And that's what got us off the ground. And I remember the cornfield on Grand Avenue. And we all knew that we were all over our head in ambition. I remember the family affair when we moved to Grand Avenue. The doctors, the wives, physically moved the beds and cabinets and linens and mattresses to our new quarters. We did that physically. I remember hiring Charlie Hoysh. I remember that I had a patient in the hospital with a bowel hemorrhage. We had no method of transfusions. We had no method of typing blood. And I knew Charlie very well. We socialized together. And I made contact with Mr. Knoll and Charlie Hoysh, and then we got the laboratory off the ground. I remember taxation. We taxed ourselves for every admission to meet expenses. Every time we admitted a patient, we taxed ourselves. I remember every staff member donating $2 for the purchase of surgical scrub suits. I think I can manage if everyone helps to make the original purchase, said Joe Back. We were that tight. And I remember a truck that he bought, a little panel truck. and he refused to put Grandview Hospital on the side of the truck because it didn't look very nice. He wasn't proud of it. But oh, how we grew. We had a 6 to 8 week waiting period for admissions. We had carts in the halls. We gave private administration, enemas, etc., in the hallway. And then we had come down to classification of admittance. We had routine admissions, we had urgent admissions, and we had emergency admissions. And then we had the inauguration of residencies. We had surgical residencies, internal medicine, and so forth. We had staff meetings in hotels because we had no facility at old DOH to have a meeting. So we had all our meetings downtown. Our meetings were ordinarily friendly, but they were argumentative and they were long. Our goal, of course, was a new facility. We hired Miriam Rosenthal, was hired as a promoter of our fund drive. I remember when we sat in a hot, unconditioned room discussing and realizing we did not have financial backing. We couldn't carry on. Miriam Rosenthal sent out, she got a couple cases of soft drinks, and that appeased us for a moment. And well, to help pacify our tired and almost deflated plans, everyone pledged to increase our ante, but it seemed we just couldn't stretch it far enough. And then GM blessed us with $110,000, and now we could move ahead. With a new facility, doctors from afar found Dayton a pleasant place. They established residential family practices. We desired lay people on our board. And I remember Dr. McCauley warning, don't give the hospital away. Remember what happened to Macaulay Propeller. And I should add here, his father had Macaulay Propeller, and he was the president. And he drew in many board members, and they eventually voted him out. Even though it still retains his name, Macaulay Propeller, he was out. And that's why he was so argumentative. He didn't want so many laymen on the board. And I remember how we grew in size and number of physicians. Many doctors visited our facilities and requested privileges. I suppose they enjoyed what they saw because they came, they observed, and they stayed. Very few Dayton DOs are native Daytonians. I wonder how many doctors and nurses, lab technicians, pharmacists, therapists ever think of our pioneer days when we concerned ourselves to our cause. Many larger cities, such as Cincinnati and Indianapolis, cannot boast of a hospital that is outstanding, progressive, and actively promotes osteopathic principles. This institution didn't just happen. It didn't just grow like topsy. It is because of the almost forgotten efforts of those who have gone on before. My wish is that we will progress and continue to grow while promoting our osteopathic tenets with pride. And I would like to add to this. I have contacts with some of the widows of our profession, and they seem so left out. And I want to pass this on to Dr. Krause, that maybe they should be remembered in some kind of contact newsletters or whatever it may be, that they are not divorced from the hospital, because they have enjoyed our progress, and they enjoyed, or I won't say they enjoyed, but they suffered with us when things weren't well. And to have them left out now isn't proper. I wish that they would be considered. That concludes my comments for the moment.
That's a very good idea. That's right.
Thank you, Dr. Baker. Does anybody else have any other comments? Dr. Hours?
Pentothal was mentioned several times during this discussion. I can recall that the coroner at one time stated that all of the cardiac arrest and surgery had been given Pentothal. For my own patients, I had 8 cardiac arrests in a 2-year period. 2 of them were children, one age 6, one age 3. At that time, we were opening the chest. Dr. Beck, Cleveland, that was the recommended procedure at that time. Open the chest, manually, take over the heart, keep it squeezed. Of those 8, we resuscitated 5 of them. The ones that we didn't resuscitate were people, I recall one had had a silent coronary while in the hospital. He'd been in the hospital for about a month with a leg gangrenous, diabetic, and he died. And one of those cardiac arrests was the doctor's mother, Canare. And she arrested before we even made the incision. Now that was later when we weren't opening the chest. Took her back to her room and we were going to do a laminectomy on her. And I told her, I said, if I were you, if I were in your position, I'd have to hurt me mighty bad to go back to surgery again. She was a devout Catholic. She said, if I go, I'm ready. But she was having so much pain that she wanted to go back to surgery, and she did well. Somebody mentioned about the food service here. I can recall when I was a resident, I could eat 2 meals a day here, not 3. If I ate 3, I got diarrhea.
Same way.
Tom Seal, Dr. Don Seal's brother, cultured potato salad, cultured E. coli. So I think things have improved. I can recall this IPPD. There was a GP from Middletown that Dr. Zimmerman had placed on that. He felt so much better, he purchased his own unit, went home with it. I think he probably turned the pressure up too high, blew a bleb, and died. Because I bought his McManus table.
You didn't buy his IPPV
Spinning? Is that Andrew Spinning? I think it was probably intentional. He was very, very bad.
Yeah. The emergency room initially in the structure at the front of Grand Avenue came down a ramp into the sort of a basement almost. The interns covered it, the residents supervised them. And I can recall we had some interesting cases. One fella came in with a paraphimosis And I was orthopedic resident. I'd never seen one quite that advanced. Ed Levine was on call at the time. So I figured, well, what should we do? So I put a glove on my hand, grabbed a hold of it, held it, squeezed it, went down, all done. Saved the dorsal slit.
What was Joe Beck's son-in-law's name? You know, yeah, he was one of the orthopedic wrestlers. Yeah, he's orthopedic. What was it? What? Joe Beck's son-in-law.
Herzog.
Herzog. I'll tell you about Dr. Herzog. Jackie, for those of you who don't remember, big, tall guy, husky. I don't know whether he played football in college, but he should have. And so one day, and this is when the emergency room is down where I guess the nuclear lab is today. And to get in the emergency room, you came in the alley in the front and went down. And so the deputy sheriff brought in a criminal. and in those days, you know, they had to go out front and fill out the papers and everything. So they brought this guy in, and I don't know what he had wrong with him, but he was on the table in the emergency room. And so apparently he had a bandage on, and the nurse approached him with her bandage scissors to remove this. And he grabbed his bandage scissors and raised up and made a pass. It just went right down flat, comatose, you know. In the meantime, the deputy sheriff, who was out in front filling some papers, come by, and Jack Herzog, he says, well, he says, I suppose I'm really in for it now. And the deputy says, Doctor, he says, I didn't see it then.
Hey, let me tell you about something about surgery. Over in the old building, we had one commode on the second floor for all the patients, and that was in the surgical scrub room. So it was very frequent we would be scrubbing for surgery, and some patient would come in, man or woman, and want to use the commode. That's all right, you just go ahead. We'd keep on scrubbing, and they would do their business. Maybe the other one would come in and do their business. It was a very common thing. But I also want to mention, too, we had a proctology convention, a national convention in 1960. And we asked all the department heads to be, I know you were there for our meeting, Bill Quinlivan, and the auxiliary were very beneficial in helping us. We put on this convention, and it was a national convention. We had around 300 attendees, and it was a very successful affair. And I don't know of any other national convention that was held here in Dayton since that time. And I should also mention that we had closed television. At that time, colored television was new, and we had about 6 or 8 televisions in the dance floor at the Biltmore Hotel. And those who could not attend the surgeries in the hospital because of room, they're able to watch closed television at Biltmore Hospital or Biltmore Hotel. And we asked all the departments to supply patients for us because we needed patients for surgery, and we had so many. I had to operate on maybe about 10 of them after the convention was over. It was all free. All free. Because we told them it would be a free operation if it would be televised and so forth. So we had so many of them, it was a good response. So, but I had to do a lot of experience. Yeah. Okay. I forgot to mention that.
Well, I think we've had a very educational meeting today, and we appreciate sincerely all of your participation and attendance. There will be a tape made of this meeting, and courtesy of the administration and Vicki, we will have each of you to get a copy of this tape. And we thank you all for coming.
Now, where is the $100 check from?
That's coming. That'll be